So my name's Martin Isabelle. I'm from Renishaw. I'm sort of switching gears a little bit. We do include or incorporate digital pathology and whole slide scanning in our work, but I'm going to talk about Raman spectroscopy imaging. We have a poster on stand 17, and we have a booth on the exhibition, so I encourage you to come and talk to me if you're interested. So I'll skip that one. So those who don't know about Raman spectroscopy, it's a light scattering technique that uses a laser essentially to interrogate tissue or cells. And essentially you get a hypercube data set that contains a huge amount of information and multiplexing information. And from that, then we can build chemical images by essentially probing the spectral range that can provide information about the proteins, DNA, and lipids. So there's a huge amount of information in that huge data set, hypercube information. So some of the benefits of Raman spectroscopy, so non-contact and non-destructive technique. We don't have to use dyes or labels. We can use bulk tissue direct from surgery, fresh, frozen, paraffin-embedded tissue. With this technology, we can do 3D volume and depth imaging. We collect topography images so we can provide information about the surface information. And we can extract out a huge amount of chemical information from the spectra, and hence it's kind of categorized as a multiplexing technique. So this is the kind of information we get from a single pixel because we've got the sort of hyperspectral data cube. We can get information about metabolomics, proteomics, lipidomics, and genomics, as well as a wealth of other information about the texture. And we can associate that with the H&E slides and the IHC slides. Just going to briefly talk about the 2-year project that we collaborated with Gloucester Royal Hospital, Exeter, and UCL. Was essentially we want to try and promote Raman spectroscopy. It's a very, very new technique in sort of the bio field. And we kind of wanted to meet the challenge of essentially trying to introduce Raman spectroscopy here. So primarily is essentially increasing awareness to pathologists and clinicians about our technique. So we sort of talked to a lot of pathologists. We attend conferences like this in the digital pathology world, clinicians. We try to investigate the unmet needs. We concentrated on GI tract, so esophageal cancer primarily, and this is what I'm going to be talking about. We optimized protocols for tissue preparation. We developed the hardware and software to allow the measurements, and we essentially then tried to look at classification models. And one of the big sort of principles of this project was data transferability. A lot of the case studies and the projects that have been done in Raman spectroscopy have been single small data sets, and there's been a real problem in essentially trying to translate this to clinic. So we wanted to tackle the multi-site data transferability problem in this project. So essentially we talked to clinicians, understood what their unmet need is, tried to establish their workflow to how Raman spectroscopy could be integrated, developed the software and hardware. We tried to optimize the protocols that work with the pathologists and the histotechnicians to provide the best quality. And then essentially with this data, then we developed software that kind of interrogated data reproducibility, the validation and transferability. And this is the machine now that we've developed. So this is a multi-site project. We're essentially collecting the H&Es and the IHCs. We also then have a sort of consecutive section that's left unstained that we measure with Raman. We managed to collect over 250 samples, looking at Barrett's esophagus, low-grade dysplasia, high-grade dysplasia, and adenocarcinoma. And we sort of essentially did single pathologists, and then we did consensus pathology review on all our cases, so make sure there was a good rigor on the pathology. We developed this case looking at 5 pathology cases, 169 cases. We first tackled the system looking at normal versus cancer, so adenocarcinoma and non-squamous. We realized that it's not a clinically relevant criteria, but it was a good set to essentially train the model, identify data transferability between the 3 different sites where we collected the data. And we got pretty good sensitivity and specificity as we'd expect with this. We then looked at the clinical relevance. This is the low risk, this is Barrett's esophagus, low grade, and then looking at the high risk, which is high grade adenocarcinoma. And we do know from the pathologists that this is a very controversial, the Barrett's esophagus and the low grade dysplasia is a really controversial, and there's a lot of pathology disagreements. So we did this over 3 sites, and we got obviously a lower percentage, but when we talked to pathologists, this was actually quite a good percentage, bearing in mind that it's a sort of controversial area, and we're also trying to move data sets and collect data sets from 3 different sites with multiple pathologists. So we're they were very happy with these kind of results. We hope to improve this by incorporating a lot more samples and going further with introducing neural networks into our classification models. So just want to end thanking people involved in the SMART Consortium, Gloucester Hospital, Exeter and UCL colleges. Really huge thanks to the pathologists and the staff, technicians at the hospitals and who we've talked to. Thanks very much.